Hello, this is Dr. Richard Phillips, the Regional Medical Director for Diabetes Interior Health. As an endocrinologist, I would like to present this short review of what I think is important in the management of hyperglycemia in the hospital setting and how to fully realize the potential of the Interior Health subcutaneous insulin prepared physician order sets, or PPOs. The Diabetes Canada Clinical Practice Guidelines for 2018 are about to be published. They identify differing grades of evidence for glucose targets in various clinical settings based on a review of the evidence. Their recommendations are as follows. For non-critically ill hospitalized patients with diabetes, pre-meal glucose targets are between 5 and 8 millimoles per liter, whereas random glucose at other times of the day should be kept below 10 millimoles per liter. This is, however, only a grade D consensus statement. For medical or surgically critically ill patients in the ICU, grade B level 2 evidence suggests that the blood sugar should be kept at less than 10 millimoles per liter, generally with IV insulin infusions. Grade D consensus is the blood sugar range should be between 6 and 10. For patients undergoing CABG, the intraoperative glucose should be kept between 5.5 and 11.1 millimoles per liter. This is a higher grade of evidence, grade A, level 1A. The remainder of the slides will focus on non-critically ill medical or surgical patients receiving subcutaneous insulin. For patients admitted to hospital with a diagnosis of diabetes, a number of factors need to be addressed in order to optimize the management of this patient population. First off, one needs to distinguish between those who have type 1 versus type 2 diabetes, recognizing that patients with type 1 diabetes require continuous insulin coverage throughout the day in order to avoid diabetic ketoacidosis, whether that patient is eating or not. It's important to document what regimen of oral hypoglycemics, insulin, and/or non-insulin injectables the patient is taking, and specifically the type, dose, and timing of insulin in order to reconcile this with the hospital formulary. Glycemic control is important to assess, as poor outpatient control, hemoglobin A1C over 9%, does predict poor inpatient control. It's important to identify those who will be eating versus those who will be NPO, as this determines which type of PPO set is to be used. It's also important to make an assessment of the patient's ability to perform self-management during the hospitalization, as those patients with type 1 diabetes, especially those on insulin pumps, may be quite capable of self-management during the hospitalization. Upon admission, due to the high prevalence of hyperglycemia in hospitalized patients and the increased complications associated with hyperglycemia, it's recommended that all hospitalized patients have a glucose measured upon admission to assess for hyperglycemia. Stress hyperglycemia is defined as a random glucose over 7.8 millimoles per liter in patients not known to have a diagnosis of diabetes. If hyperglycemia is discovered, it's recommended that a hemoglobin A1C should be ordered to distinguish those patients with stress hyperglycemia from those with undiagnosed diabetes. Patients with undiagnosed diabetes will have a high hemoglobin A1C. Patients with a known diagnosis of diabetes should have a hemoglobin A1C drawn in hospital if one has not been done within the past 2 to 3 months as an outpatient. If the hemoglobin A1C is high, this is helpful in predicting worse inpatient control and thus higher insulin requirements, as well as a need for treatment intensification upon discharge. What about the role of oral hypoglycemic agents in hospitalized patients? Under most circumstances, for acutely ill patients, oral agents should be held. Metformin is problematic due to renal dysfunction, intravenous contrast exposure, and various hypoxic states common in hospital. Sulfonylureas are associated with severe and prolonged hypoglycemia. TZDs cause fluid retention and have a slow onset of action. DPP-4 inhibitors are generally well tolerated, although there is a caution specifically with saxagliptin for its use in patients with a history of CHF. GLP-1 receptor agonists are inappropriate due to the frequent development of nausea upon initiation of this class, as well as their ability to slow gastric emptying. The SGLT2 inhibitors are of particular concern regarding the possibility of inducing euglycemic diabetic ketoacidosis. This rare complication is more common in physically or medically stressed patients. Thus, they are uniquely inappropriate in the hospitalized setting. In general, the preferred treatment of hyperglycemia in non-critically ill medical and surgical inpatients is with insulin. Insulin is most effective if ordered as a basal-bolus regimen of multiple daily injections of scheduled subcutaneous insulin comprising 3 components: basal background insulin in combination with bolus or prandial insulin in association with a correction or supplemental insulin, the ISF. Clinical experience and clinical studies have shown that sliding scales never work, never have, and never will if they are used as the sole means of controlling hyperglycemia in hospitalized patients. Sliding scale insulin has been compared with basal-bolus insulin regimens in both medical and surgical patients in the so-called RABBIT-2 studies, and it's been found that basal-bolus insulin is much more effective at meeting glycemic targets than sliding scale insulin. Thus, the basal-bolus insulin regimen is the basis upon which the subcutaneous insulin PPOs have been based. Having said that, there certainly are barriers to the use of basal-bolus insulin. Hyperglycemia is frequently not the focus of the patient's admission. There is an inherent complexity of the basal-bolus insulin regimen. There is varying physician comfort with ordering insulin. There's an increased workload placed upon nursing to test glucose and to calculate bolus and correction doses with each meal, and a requirement for the insulin to be administered within 15 minutes of a meal. Insulin doses may need adjustment as frequently as every 1 to 2 days based on pattern recognition of the glucose profile in the chart. There is an inherent risk of hypoglycemia with insulin. Insulin is known as a, quote, high alert medication due to its potential for risk of harm from hypoglycemia. The following slides, entitled Insulin Orders Made Easy, provide guidance on how to optimize the use of the subcutaneous insulin PPOs in hospital. Number 1, if the patient is on a basal-bolus regimen at home and that regimen is working well, and the patient will be eating meals without interruption in hospital, then it is best to continue the home regimen. The home regimen doses may need to be reduced by 20 to 25% if oral intake will be less in hospital than at home. Many patients with type 1 diabetes will be comfortable and capable of self-management in hospital, and this needs to be recognized. The use of a structured written insulin order set, such as a PPO, and in the future, computerized physician order entry is the most appropriate way to order insulin. Number 2, if the patient is not on a basal-bolus regimen at home and will be eating regularly in hospital, one calculates the total daily dose based on the patient's body weight. Most patients will be on 0.4 to 0.5 units per kilo per day, depending on the admission glucose. If the admission glucose is less than 11.1, total daily dose should be 0.4 units per kilo per day. Admission glucose high over 11.1, 0.5 units per kilo per day, total daily dose is an appropriate start. Using a lower total daily dose is appropriate for older individuals and those with renal impairment, arbitrarily a creatinine of over 170. Using 0.3 units per kilo per day total daily dose due to the higher rate of hypoglycemia in this patient population. Number 3, a common mistake is to order basal insulin without ordering scheduled bolus insulin. If the patient is eating meals, scheduled bolus insulin is required. The total daily dose is divided between scheduled basal and bolus components. 50% of the total daily dose is given as a long-acting basal insulin, such as insulin glargine or NPH insulin, usually given once daily at bedtime. The other 50% of the total daily dose is given as bolus insulin, such as NovoRapid or insulin aspart, divided equally with 3 meals, as long as the patient remains eating. Number 4, once one has decided upon a scheduled basal dose of insulin glargine or NPH and a scheduled dose of bolus insulin with insulin aspart, one needs to decide upon the supplemental insulin known as the ISF. The correction dose or insulin sensitivity factor, ISF, is based on the total daily dose and the so-called rule of 100. One divides 100 by the total daily dose to determine the ISF. For example, 100 divided by a total daily dose of 50 units daily equals an ISF of 2. This implies that 2 units of insulin aspart should correct or reduce the glucose by 2 millimoles per liter. Number 5, if the patient misses a meal, then the bolus or prandial insulin component needs to be held prior to that missed meal. If the patient misses a meal or meals, the correction supplemental dose should be given if the glucose is above the target range. If the patient has made NPO, the basal component should continue as before. Number 6, if patients are NPO, then the NPO subcutaneous insulin prepared physician order set should be used. This provides basal insulin as well as a correction dose of insulin aspart if required. One calculates the basal insulin dose requirement again by body weight. If the admission glucose is less than 11.1, then the basal dose provided should be 0.2 units per kilogram per day. For higher admission blood glucose over 11.1, calculate the basal insulin dose at 0.25 units per kilogram per day. One does not order scheduled bolus insulin if the patient is not eating. One can calculate the correction dose, or the ISF, by dividing 100 by the total daily dose multiplied by 2. Using the PPOs to order basal bolus insulin, will go a long way to optimizing glycemic control in hospitalized patients with diabetes. But because clinical circumstances frequently change throughout the hospitalization, the orders may need to be adjusted to stay on target. The following do's and don'ts need to be considered. If your patient's glucose is frequently between 4 and 5 millimoles per liter, it's best to reduce the relevant insulin doses by 10 to 20% to avoid future hypoglycemia. If the correction dose is being given frequently, this suggests that the scheduled insulin needs to be increased. If glucose is high throughout the day while on basal insulin alone, this clearly suggests the need to add prandial insulin instead of increasing the dose or the frequency of basal insulin, as long as the patient is eating. Simply increasing the basal insulin runs the risk of so-called over-basalization. It's important to adjust the insulin frequently depending on glucose control, using pattern recognition when looking at the glucose log in the chart, as well as adjusting insulin based on patient factors, changes in nutritional status, upcoming procedures, use of glucocorticoids, etc. A general rule of thumb is that correction or supplemental insulin is generally not needed at bedtime and may increase the risk for hypoglycemia if used. Is there an alternative to basal-bolus insulin in hospitalized patients? Based on the results of the Basal-Plus study, using basal insulin and supplemental insulin may be effective according to this particular study protocol. This strategy may be appropriate for patients with diabetes admitted to hospital who are normally on oral agents alone or on a relatively low dose of insulin of less than 0.4 units per kilo per day. With this strategy, one uses basal insulin, such as insulin glargine, at 0.25 units per kilo per day, along with a correction dose without using scheduled bolus insulin. In order for this strategy to work, instead of basing the ISF on the total daily dose and the rule of 100, one uses an aggressive ISF of somewhere between 1 and 2. This regimen would not be expected to work for patients admitted with significant hyperglycemia or for those who are on insulin in greater amounts than 0.4 units per kilo per day. A word on the transition of patients from the ICU to the medical or surgical ward. For those who are on IV insulin infusions, transition to subcutaneous insulin requires an overlap of insulins. If eating, give rapid-acting insulin, insulin aspart, pre-meal, but stop the IV insulin 2 hours later to provide an overlap. If the patient is to remain NPO, give long-acting basal insulin, such as insulin glargine, at least 2 to 4 hours before stopping the IV insulin infusion. One can calculate the basal insulin by looking at the IV insulin rate over the preceding 6 to 8 hours and extrapolate that over a 24-hour period and provide about 80% of that insulin as the basal dose. Alternatively, one can simply base the basal dose on patient weight using the guidelines of between 0.2 and 0.25 units per kilo per day as outlined earlier. With regards to steroid-induced hyperglycemia, all patients without known diabetes who are initiated on glucocorticoids in hospital should have their glucose monitored for at least 48 hours to assess for the development of hyperglycemia. It's important to check the glucose with fingerstick glucose checks in the afternoon, for example before dinner, and not to rely on fasting glucose checks, as patients on prednisone frequently have relatively normal fasting glucose, but will be significantly elevated later in the day. Steroid-induced hyperglycemia is best treated with insulin, and the doses frequently required are higher than the typical total daily doses of non-steroid treated patients, thus doses greater than 0.4 to 0.5 units per kilo per day. The hyperglycemic effects of morning prednisone are most often seen in the first 12 hours after dosing. Thus, when providing insulin, the insulin should be so-called front-loaded. This means giving most of the insulin in the first 12 hours of the day and much less in the latter half of the day. For example, often a single dose of morning NPH insulin may suffice when added to the usual home regimen. If a patient's on prednisone 40 milligrams per day, a useful rule of thumb is to provide NPH insulin at 0.4 units per kilo per day once in the morning. If the prednisone dose was 60 milligrams per day, it would be 0.6 units per kilo per day. 20 milligrams per day, 0.2 units per kilogram per day, once daily dose in the morning. For longer-acting glucocorticoids such as Decadron, because this steroid preferentially raises postprandial glucose, it's best to manage these patients with longer-acting basal insulin analogs, such as insulin glargine, as part of a basal-bolus regimen, with 70% of the total daily dose given as prandial insulin and a minority, or 30% of the insulin, given as the basal component. Managing enteral feed-induced hyperglycemia can be a challenge. One needs to match the bolus insulin to the amount of carbohydrate provided in the tube feed. This requires one to read the label in order to determine the carb load. For a bolus feed regimen, a basal bolus regimen of insulin is provided. The basal dose is calculated as 0.2 to 0.25 units per kilogram per day, given as once daily glargine or twice daily NPH. And the bolus insulin is given pre-feed, 1 unit of aspart per 10 to 15 grams of carbohydrate, plus an insulin correction dose if required on top of that. For continuous feeds, a number of strategies have been recommended, one of which is to provide a basal bolus regimen with basal insulin 0.2 to 0.25 units per kilogram per day, provided as either once daily glargine or twice daily NPH, and the bolus insulin given as 1 unit of aspart per 10 to 15 grams of daily carbohydrate, divided into 4 Q6 hourly doses plus correction. Due to the relatively short action of insulin aspart, others would actually divide the bolus insulin into 6 Q4 hourly doses. This particular regimen of BID NPH with frequent novorapid boluses for the continuous food regimen is recommended due to the frequent occurrence of the tube feeds being held or interrupted, which would put patients at risk of hypoglycemia if simply using high basal doses of insulin were used instead. For TPN-induced hyperglycemia, one may simply add short-acting insulin to the TPN solution at a dose of 1 unit per 10 grams of carbohydrate and adjust every couple of days depending on response. One may also use the strategy for the continuous enteral feeds, that is, providing basal insulin, either once daily glargine or twice daily NPH, at the usual dose of 0.2 to 0.25 units per kilogram per day, along with a rapid-acting insulin aspart at 1 unit per 10 to 15 grams of carbohydrate, administered either every 6 hours in 4 divided doses or every 4 hours in 6 divided doses, with correction doses as required. Some final thoughts with regard to the patient's transition to home. If the pre-admission glycemic control was adequate, then resume the outpatient regimen upon discharge, or even 1 to 2 days before discharge. If patients are new to insulin, they and their families need insulin teaching, oral and written instructions of dose and timing, as well as identification of which healthcare provider will be responsible for timely follow-up. Needless to say, the primary care physician needs timely notification of the discharge insulin regimen. Basal-bolus insulin regimens as used in hospital are often too complex for older patients with comorbidities to cope with upon discharge. As such, it may be best to discharge these patients home on oral agents plus basal insulin alone at 50 to 80% of the inpatient dose. Not all patients will be able to afford insulin glargine, as this is not covered under pharmacare unless under special circumstances. Thus, sending the patient home on NPH insulin may be appropriate as it's fully covered by pharmacare. I hope this short tutorial has been helpful, and I wish you success in managing your patients with diabetes on the medical and surgical wards by optimal use of the eating and NPO physician-prepared order sets. Thanks very much for listening.